My name's Chris Weeks. I'm a obstetrician and gynaecologist working at Nambour Selangor Private Hospital, and I've been there since January of this year. I'm there once a fortnight, as I'm mainly at the Sunshine Coast University Hospital working in the public system. And I also operate up at Noosa publicly and also down at Caboolture privately as well. So tonight I'm going to talk to you about common gynecological conditions and their management in the community. I thought because I had fairly short time to talk tonight, and I'll just do a quick overview of some of the more common conditions which I think you would be seeing, and that get referred to us and potentially could have been initially managed through their primary carer. So my first condition I'm going to talk about is overactive bladder. So I've got FUN there because that's the acronym I use to help remind junior doctors and registrars about the symptoms that lead to overactive bladder, being frequency, urgency, and nocturia. And if a woman is experiencing all of those or any one of them, then she likely has an overactive bladder. This can be associated with bladder pain, dysuria, other pelvic floor dysfunctions, and can be quite debilitating, especially if a woman gets to the stage where they cannot leave the house. They're fearful of wetting their clothing, fearful of going out and doing activities. So investigating a woman who you feel has OAB, perform an MSU to rule out recurrent urinary tract infections or colonisation of the bladder. If there's associated hematuria, think about other possible causes and perform urinary cytology to rule out anything nasty going on. Consider a bladder scan or pelvic ultrasound if you think there might be a mass involved or there's incomplete emptying. And look into whether they might have diabetes, heart conditions, renal conditions, which could be contributing to their symptoms. In terms of management, a woman's health physiotherapist can be a fantastic port of call and get them to start doing bladder retraining and lifestyle measures. And then directing them to a website such as continence.org.au can be very helpful to give them some ideas and management strategies. Medications can be very helpful, and my favourite is Betmega. It is a bit expensive because it's not on PBS and will cost them about $50 a month. But after they've been on it for a while, you can drop it down to second daily, which will halve the cost. Commence on 25 milligrams mostly, but for a young woman who doesn't have hypertension or other comorbidities, starting on 50 milligrams daily is quite reasonable. VisiCare, not a huge fan because I feel that you still get a lot of the side effects of the anticholinergic. So you might as well give them oxybutynin, inditropan or oxytrol patches because that's on the PBS. It's going to be more cost effective. NDEP is a fantastic medication which I think helps a lot of women, especially if they've got that nocturia or bladder pain. Start them off on 10 milligrams Noctay, increase the 20 milligrams if they're tolerating it well. And if that's the case, put them on a 25 milligram tablet to continue on. Refer these women if they're failing to improve with simple measures. If they've got some red flags, abdominal pain, mass, dysuria, hematuria that's persistent, or incomplete voiding, or they've got a prolapse on examination which you feel could be contributing significantly, if it's associated with that stress incontinence or the prolapse. Pelvic organ prolapse. So a woman will present with heaviness or dragging or a lump at the vaginal opening. She might have some bladder changes or bowel changes which are concerning her, or even sexual changes which are concerning her. Investigation of these women, so examine these women, make sure you're looking at their individual compartments. And my way of doing that is I get a plastic speculum, take the screw off, break it in two and use it as a Sims speculum, and you'll be able to look at the anterior vaginal wall, posterior vaginal wall and the uterus and cervix and see where they're coming down to give a better overall picture of where the prolapse is. Think about doing a POP-Q assessment and have a look online to see how to do that. And it can be a helpful way of guiding you and potentially having a look and seeing what their progress is over time. MSU is important, and consider whether a pelvic ultrasound is necessary. I don't think so, most of the time. Management, physio again. Find a good women's health physio who you trust, who women like to go and see, and they can be a huge asset. Physios can teach them how to do pessaries, so rings, gel horns, other types, and they can insert them and remove them. Manage their bladder, manage their bowels, make sure they don't have that overactive bladder, make sure they're not constipated, and manage and treat those problems. Refer them if it's severe prolapse, if they're not improving with treatment, if it's very bothersome and they want surgical management, or if it's recurrent, especially with previous mesh insertions, especially in this current environment with the mesh concerns. Moving on to heavy menstrual bleeding. So this is just a perception of heavier than normal bleeding. So it can't be quantified, it's what the woman perceives. And if she's iron deficient anemia and other causes have been ruled out, then obviously that's another cause for concern. Investigate these women with a full blood count, iron studies, pelvic ultrasound, cervical screening test, endocervical swab looking for chlamydia, gonorrhea, other STIs. Think about TSH, whether that could be contributing. Think about prolactin, could that be contributing if they've got irregular menses? Think about PCOS investigations. Manage these women non-hormonally with tranexamic acid and Ponstan. I think this as a combination can be very effective and reduce their bleeding by about 40%. And hormonal managements such as the oral contraceptive pill, depot injections, Mirena, Primulate, multiple things you can try. Mirena is obviously our favourite as gynecologists. It has good evidence. It's accepted by most women. There are a lot of GPs in the community who can insert them. So it's a fantastic first line management. When to refer, if they've got acute bleeding, if they're over 45 and there's a change in their bleeding pattern, if they've got an abnormal ultrasound, thickened endometrium, fibroid, polyp, anything, if they've got postcoital bleeding or intermenstrual bleeding, which is concerning you, or if they've got an abnormal examination, so abnormal appearing cervix, a polyp, you can see a big bulky uterus when you do a bimanual examination. Dysmenorrhea. So this is pain with menses or around their menstrual cycle. It can be associated with other problems such as bladder changes, bowel changes, mood problems, headaches, and always got to ask the question with dysmenorrhea, could this be endometriosis? Do they have some of the other dysses, as we say? So not only dysmenorrhea, but dysuria, painful bladder function, dyschezia, painful bowel motions, dyspareunia, painful sex. If they've got that constellation of symptoms, they're more likely to have endometriosis, especially if this commenced in adolescence or their early 20s. Investigate these women again if they've got heavy bleeding, full blood count, ferritin, do a pelvic ultrasound, and consider sending these women to an advanced women's imaging place if you're thinking endometriosis, because they can look for those deep infiltrating endometriotic lesions. They can look for endometriomas and other concerns like that. Management, hot packs, not using them judiciously. We sometimes see women who use them all the time and actually get that like scarring appearance over their belly from overuse of hot packs. Exercise, movement has been shown to be very helpful for these women, especially if they've likely got some pelvic floor overactivity or dysfunction. Ponstan, NDEP, can be very helpful. Tranexamic acid if they've got heavy periods. The Mirena, the pill, implant on depot, other hormonal managements. At physio again, getting them along to them, managing their bowels and bladder, thinking of it holistically. Refer these women if you think it's endometriosis, you do need surgery. If the scan is abnormal, and there are other features which could suggest a cause for this, such as adenomyosis or fibroids, ovarian masses, or if it's severe, or if it's not improving, of those measures. Chronic pelvic pain. So this is where we get more into those random pains at any time of the month. They can be in their lower abdomen, their pelvis, back, groin, can be associated with other changes such as headaches, bowel, bladder, sexual function difficulty. So investigate these women much the same way. Do an ultrasound, do a urine, do swabs, look at their bowel as well, because not all chronic pelvic pain is gynae related. And very often it could be irritable bowel syndrome, ulcerative colitis, or other inflammatory bowel conditions, constipation, etc. Manage these women with simple analgesia. Avoid opioids at all costs. Hot packs, exercise, physio, get them on medications such as gabapentin, Ndep, diazepam. And one speaker I heard recently talks about PR diazepam being used for severe flares to keep them out of hospital. Think about sending them to a chronic pain physician or a psychologist, and refer these women if you've got an abnormal ultrasound, if there's likely to be endometriosis or if there's a pelvic mass on scan, and they're refractory to management. Vaginal thrush and PV discharge, another very common condition. So these women will often present with abnormal discharge or just vaginal discomfort or even dyspareunia. But the take-home message from this slide is that there may just be normal discharge, and after investigations and examination, perception management and reassurance may be all that's needed. So investigate these women with swabs, do a cervical screening test if it's not up to date. Think about a pelvic ultrasound, especially if you're thinking, could this be PID or a tubo-ovarian abscess? If it comes back as Candida, manage that. So vaginal, caniston, pessaries, cream, whatever the woman prefers, oral fluconazole. And if it becomes chronic or recurrent, one management I have is using 50 milligrams of fluconazole on a daily basis, long term. So keep them on it for 3 to 6 months until those symptoms resolve. That's quite safe. There are some potential liver effects. So if it's going to be longer term than that, then doing liver function tests would be a good idea. The alternative to that is weekly fluconazole doses of 150 milligrams, again, until their symptoms resolve. Treat chlamydia and gonorrhea, obviously, if it's present. Bacterial vaginosis, treat it as symptomatic. So if they've got the discharge, fishy smell, discomfort with sex, that's an indication to treat. If it's picked up accidentally, don't need to treat it, unless they're going for a myelina or some other gynecological procedure, which will help reduce the risk of infection on those procedures. So refer these women if it's chronic, if it's recurrent, not getting anywhere, or if you're concerned about pelvic inflammatory disease or a tubo-ovarian abscess, such as associated with pain, discharge, and fevers. PMS and PMDD. So PMS is premenstrual syndrome and premenstrual dysphoric disorder. So these are mood changes, other changes related to the luteal phase of the menstrual cycle. And 80% of women will have some form of PMS. 4 to 8% of them will experience severe symptoms, and 2% will go on to actually be qualified for a diagnosis of PMDD. Investigate these women with, normally you don't need to do any investigations, but maybe a hormone profile, maybe a TSH if you think that's indicated, maybe a prolactin. Think about a pelvic ultrasound if they've got some other problems such as pelvic pain, but otherwise no specific investigations are needed. Management of these women. The oral contraceptive pill is a very good management. It shuts down the ovarian, this luteal phase and the cycle, shuts down the ovaries, and a lot of evidence is associated with the pills associated with that have drospirenone in them, which is Yaz, Yasmin, Yazflex. I recommend giving these women the pill continuously. And a lot of the other conditions, dysmenorrhea, heavy menstrual bleeding, quite reasonable to put a woman on the pill and get them to just have a bleed once every 3, 6, 9, 12 months. That's perfectly safe, perfectly reasonable. And as long as they're not getting that breakthrough bleeding. Think about an SSRI, low dose, fluoxetine, sertraline, either just in that week before their period or continuously. Send them off to a psychologist for CBT and refer them if it's severe, refractory, you think it's getting into this PMDD stage. Menopause. So this is the absence of menses or symptoms of menopause. So some women will have just the hot flushes and mood changes, insomnia, vaginal dryness, especially if they've got a Mirena in or if they've had a hysterectomy. Obviously, you won't have the periods to guide you. So investigation, look, nothing specific needs to be done. If this is over the age of 40, their periods have stopped, they're getting some menopausal symptoms, you can treat them as being postmenopausal. But if it's premature, so less than 40 early, or premature less than 35, then investigate. So hormone profile, FSH, LH, estradiol to confirm the diagnosis, beta-HCG to make sure that they're not pregnant, and AMH, especially if they're concerned about fertility effects. Management of menopause. So a lot of women will take alternative medicines, which may include black cohosh or St. John's wort or multiple other phytoestrogens. Not a lot of evidence. Black cohosh might have some for hot flushes. St. John's wort might have some for some of the mood changes. But look, if a woman is using it, it's not affecting her other medications, not causing any other complications. No dramas. Hormone replacement therapy, if they've got a uterus intact, using a progesterone, and that can be in the form of Mirena, which takes away the need for a combined patch or a separate pill. The most safest form of estrogen is transdermally. The safest form of progesterone is prometrium. So using either a patch or a gel is quite reasonable. But if they've been on a HRT, leave them on the one that they're on. If it's working well for them, there's a lot of evidence such as telling us now that HRT is quite safe and probably has a lot of other benefits to women for their long-term health. Other options apart from HRT, so venlafaxine, paroxetine, clonidine, gabapentin. Therapeutic guidelines have some very nice guidelines in terms of the doses for these medications. Think about vaginal estrogen, if that's all they're complaining of is vaginal dryness and dyspareunia. The Mona Lisa touch is not something that I would necessarily say is recommended because it's controversial in terms of its effectiveness, but a lot of women do swear by it. And there is, I think, Beverly Powell doing it on the Sunshine Coast and gynecologists on the north side of Brisbane doing it. But it does cost money as well. And it's not a once-off treatment. The woman will have to keep on going back for further treatments. And essentially, it is a laser to the vagina. The device is placed in the vagina, and the laser is turned on, and it causes essentially a dermabrasion, which the idea is it'll damage the cells enough that they'll come back at a healthier level. There'll be improved lubrication, improved flexibility to the vaginal walls. And some of the women I've seen who've been refractory to any other treatment have been sent off to have it done, have come back very happy. So refer them to me if they're refractory, if they're unsure if you're able to use HRT, or if they're in premature menopause or early menopause. So we'll stop there and I'll come back online and we'll talk about these conditions and answer any questions that you might have about this talk or anything else that you're seeing in your practice.